Hi, everybody. My name is Dr. Jacob Strand, and I'm the chair of the Center for Palliative Medicine at Mayo Clinic. And I'm here to talk today about advanced care planning. And I want to go through a couple of things here. And the first is just to identify why we're even talking about this. So why does advanced care planning keep coming up in both the media, but also in patient advocacy groups, in clinical settings, and amongst care providers? And I'd like to talk a bit about what high-quality advanced care planning actually looks like, moving beyond checking boxes and really into helping it align with a patient's and their family's goals, preferences, and values. And then also to give you some questions that you can ask in discussions with your family, with your physician or care provider, and even to think through as you decide how to move forward with your illness and within the construct of providing this advanced care planning as really a gift for yourself and for your family. So I think importantly is just to talk about why this keeps coming up in a lot of different forms, as I mentioned earlier. And it's because what research continues to show is that there is a gap between what patients describe they want and what they end up getting as a result in care settings. And I think a lot of that has to do with things like when we think about treatment of disease and symptom management and quality of life. These are key aspects that patients describe. And this, I'm oversimplifying this, but there are a number of things that are related to both the treatment of disease, but also both that what does that quality of life look like during treatment of the disease, and what does it mean to have some sense of control, some sense of being able to have life completion, either treatment completion, care period completion, completion of a long journey with an illness. It can mean multiple things to different people. And also importantly, a clear desire to strengthen relationships within the context of their own life. And one of my colleagues, who's the director of quality projects at the Dana-Farber Cancer Institute and for the Center for Palliative Care there, has talked a lot about this idea that unfortunately our conversations about things that are important to us as patients and giving that to our providers, these conversations are too little too late and just not great. And unfortunately what that means is that we see a significant delay in discussions of care preferences until a very late stage of an illness, even at the end of life. For patients with advanced cancer, we see that conversations, for example, about end-of-life care and what things are important to patients about end-of-life care took place, unfortunately, not until often the last month of life. That most of the conversations around end-of-life care took place in a hospital setting. And that unfortunately few conversations took place with that patient's treating oncologist or surgeon, who is often the person best positioned to have that conversation, has the deepest relationship. And unfortunately, when these conversations do take place, we see that they fail to address some key quality components, specifically talking about prognosis. And I don't just mean time. What I more mean is actually this idea of what does life look like as one goes through the course of a disease, even a curative intent treatment course. And as well, that failure to bring in family support is another thing that's often lacking in these conversations. What we also see is that caregivers, whether that's the patient's family members or close friends or other people who are caring for them, describe a number of concerns about planning, that they haven't had enough communication with physicians, that there's not enough emotional support. A lot of people talk about this idea that for a patient who is progressing into a phase of end-of-life care, there's not enough information about what that might look like, and concerns about poor symptom control. We also see that when we do this, though, when we have these conversations between patients, our family caregiver units, and clinicians, that it does a number of really important things. It honors patients' wishes, increases overall quality of life, and actually reduces stress, anxiety, depression, and post-traumatic stress disorder symptoms in family members who are taking care of patients who are facing a serious illness. And I think from the clinician perspective, one of the things that I see play out day in and day out is that when we're able to have these conversations, it strengthens the bond and the relationship that I have with some of my patients and their caregivers. So I think part of this is, what do we do then? How do we bridge the gap between what patients want and what they're getting? And so I'm going to put this fancy graph up there and just outline a number of terms that we'll talk about more in panel discussions, and I'm sure you'll see again in other settings, which is this idea of overall advanced care planning. What does that mean? It's the idea of trying to do some planning for what a person may want in the context of a serious illness. Now, that may take place when someone is young and healthy. When I got married, my wife and I put together an advanced care planning document. It was pretty bare bones because we were both young, healthy people, and really talked about who we wanted to speak for us, and some of the things that came to mind in that context. For someone with a more advanced illness, say a diagnosis of cancer, a diagnosis of a metastatic cancer, we think about this idea of serious illness care conversations. And really that's planning in the context of a progression of a disease. This might be, again, in the cancer context, a recurrence, or a surgery that didn't go well, or a chemotherapy that didn't achieve the desired goals. And those conversations then are aimed at talking through some of the things that are important to that person and their family as they move forward with that illness. When we say the term goals of care, sometimes it's used to mean a variety of things. I'm going to use it more in the context of making some tough decisions in the setting of something that really bad has happened. Again, a much worse progression, a crisis. So what does it mean now when we take the goals and values and preferences that a person may have been able to share with their clinicians, with their family, and then apply that in the context of the medical realities facing us? And I think you'll see a variety of ways that these are used. So Mayo Clinic has a really extensive advanced care directive, or advanced healthcare directive, or advanced care planning document. There are also great websites like prepareforyourcare.org is another site that has a lot of great information that walks patients through information about how to have these conversations. The Go Wish game is actually a fun one where you sort of talk through some of the things that you are hopeful for in a card format for people who like to do that. And these are all forms of having these advanced care planning or serious illness conversations. But I think importantly is whatever form is used is that these conversations are not done well by just checking boxes. And you'll see this a lot in a number of these forms. And some boxes are important to check. It's often important to check if you have someone already named to be your surrogate decision maker. It's important to check boxes if certain parts of care, or even things like resuscitation preferences, are very important to you, having had conversations about this. But in general, these conversations, these advanced care planning conversations, are important and require the context of prognostic awareness. So what does the disease look like as a patient moves forward in that journey? What is likely to happen as time moves forward? And they also need to take place when patients aren't struggling with an acute illness. Now, sometimes we need to have those conversations, but ideally we're having them in times of wellness where there can be a thoughtful back and forth and lots of time for processing and questions. And again, they need to focus on goals and values, not just I don't want this or I do want this, because number one, that's hard to understand at any time point. It's also that things do change, and so being able to have goals and values inform those decisions as they come forward, and they often do better when they involve surrogate decision makers and guidance from clinicians. And those components, when we do it well, as I mentioned earlier, I'm just going to say it again, much better outcomes for patients. We do better at providing the care that patients say they want. We do better at supporting patient quality of life, supporting patient mood and coping skills and patient satisfaction. And I think what this often looks like, and what we talk as palliative care clinicians a lot about, is number one, how do we talk about prognostic awareness? So this idea of patients and family members can understand what is likely to be ahead, even when it may not be completely clear. That teams, as patients process this information, can help promote coping strategies so that patients can live out all of their goals and their values in whatever ways that we can, as care teams, support them. And then that decisions about goals of care, remember those decisions about specific types of care, are put into that broader context of goals, preferences, and values, and can then inform more practical medical decision making. And at the end, if we do this well, we can deliver treatment that's very consistent with goals and values. And so again, this looks easy. This is really hard to do, but when done well, it has really important positive ramifications for patients and their loved ones. Part of the reason why this is hard, though, is that patients and clinicians, frankly, struggle to understand prognosis. And often, people are appropriately moving back and forth in their own mind between more realistic hopes and things that are maybe less realistic. And frankly, that's okay and normal. It is actually more worrisome to me when people get stuck on either end. If people are focused too much on exactly what is going to happen next, how does one able to be present in the moment of that day, that hour, that experience with their family? If we are always focused on hopes that are less likely to be realized, then sometimes planning can be challenging, and that can this swing, therefore, is actually okay and important for us to recognize as clinicians and as family members. The other piece is that understanding what lies ahead is really important from this idea of prognosis. Again, the idea about what is my life likely to look like as I move forward. And most patients with cancer want to know what that looks like, and because it helps with decision making and planning. We also know that it doesn't compromise hope, that actually helps patients make decisions that are more in line with their goals than it does without that information. And so some of the questions that as a patient are so critical to arm yourself with before some of these conversations are really to think about, so if my health gets worse, what things are most important to me? What goals do I want to make sure to achieve? What are some of my biggest worries about my health as I move forward? Sometimes I have patients who tell me they want to make sure they're able to still have conversations with their loved ones and have the mental clarity to do that. And not having that clarity is a really big worry. And so we want to know that for multiple reasons, not just about what happens in the future, but what happens now so that we can enhance that person's ability to have energy and to be clear in all of the moments ahead. What are some things that are so important to me that I can't imagine living without? I had a patient tell me once that, he had worked in a bakery and said, look, I'd rather have sweet roll in my lung than a feeding tube in my stomach. That was really helpful. It was a graphic image, but very helpful for me to understand what was really important to that person. To that person, it was so critical to be able to eat independently. And how much does my family know about what's important to me and my priorities? Sometimes we think that our family members know all the things that we have, but that can be challenging if we actually haven't had the conversation. And I think it's important that we focus on those questions and those broader goals as opposed to just, again, this checkbox or what are your resuscitation preferences or would you want to be on a ventilator? Those are medical decisions that are really influenced by goals, preferences, and values, but aren't the output of these conversations. We want to focus on what's important to you and what does it mean for us to know you as a person in your environment, in your family setting. And so, again, moving away from some of those broad pronouncements that don't have clarity and that are quite individual. When people say, I want everything done, that can mean very different things to different people. I've had patients say, I never want to go to the nursing home, but then when you talk with them, they are willing to do certain things when put into the context of both the goals that they have for their life, the important things they want for their family. And sometimes there are decisions that are changed as we have a broader conversation as opposed to some of these difficult statements, which, again, important. People have them, and it's okay to have them. What our focus as clinicians, if we do this well, is to push people to expand upon those definitions and expand upon those values to get at what it means to them in their life. The other piece I'll end with in the last minute or two is this idea that this is hard work. And it's hard because our brains often segregate some of these things into very cognitive statements and emotional statements. And overlapping them can be really challenging. And so as clinicians, we struggle with having these conversations because we are worried about emotion. We are worried that patients may get sad in talking about this. I was sitting with a patient yesterday who his prognosis actually is likely in some number of many years. But he wanted to talk about some ideas for his family and some things that were important to him, and he got tearful. His wife was tearful during this conversation. That was normal. That was okay. And it doesn't mean that the conversation wasn't important. In fact, at the end, they were both very grateful to have had the chance to talk through this. But sometimes physicians are really challenged to respond to these emotional cues as opposed to the data. It's not just for those of us who might consider ourselves touchy-feely types in terms of our ability to emote and talk about some of these emotions, but being able to respond to some of these some of these worries, some of these concerns, some of the sadness that can come, can actually lead to a deeper discussion and can lead to improved patient outcomes by better understanding where patients are coming from. I think importantly, and one of the last thoughts I want to leave you with, is that language is so important. for all of our patients, when we talk about advanced care planning, this is not about end-of-life planning only. And it's not only when patients are really sick. The goal here is to improve care for all patients with a diagnosis of a serious illness, whether they have curative intent therapy, whether they're going to live for the next 30 years with their illness, or whether they have a more challenging course ahead. Because most patients who benefit from talking about their illness and their goals, planning for what may happen if they get sicker, aren't dying. And it's important for them to be able to verbalize the care that's important to them so that we can provide that care consistent with their goals, preferences, and values. What I'll end with here is that this is something, in talking about advanced care planning and cancer care in particular, is important for everyone. And what we are always searching for is ways to continue to support patients and their family and their caregivers in ways that help them realize their own individual desires and how that fits into the context of their family unit, their social structure, and leaves them feeling supported in it moving forward. With that, I'll end and look forward to the conversation.